Hello, everyone. Welcome to the Preemie Chats. Preemie Chats is our weekly educational session for healthcare professionals and parents to talk about what matters to you, to explore new ideas, and to learn together. I'm Fabiana Bacchini. I'm a Preemie parent and executive director of the Canadian Premature Babies Foundation, as known as CPBF, and I'm happy to be your host today. CPBF is a parent-led charitable organization that helps families in and after the NICU through education, support, and awareness. If you have a heart for preemies, whether you are a family or a healthcare professional, please check our website at canadianpreemies.org. There you'll find resources, the latest projects, and most importantly, a community of people who want to see our little babies thrive. If you're watching live, please bring your voice to this table. Leave comments and questions in the chat, and you try to address them during our program. It is through rich conversations like this that we can advance practice and learn together. So please participate and let us know where you're watching us from. And now on today's topic. So May 15th is World Kangaroo Care Awareness Day. This is the second live this month about this topic. And today we'll have 4 incredible speakers sharing their expertise and views on kangaroo care, skin to skin. And they are joining us from different parts of the world today, which is very exciting. And our first guest today is Professor Paul Clarke, who will talk about the vital importance of birth cuddles for extremely preterm babies and their parents. Professor Clarke has been a consultant neonatologist at Norfolk and Norwich University Hospital in the East of England since 2005. He has a keen interest in clinical research in neonatal medicine and has more than 130 original research publications. He's a fervent advocate for early delivery room contact between parents and their newborn premature babies, and he has lectured widely, both nationally and internationally, on this subject. This topic holds a dear place in his heart. Professor Clarke, thank you so much for joining me today, joining all of us from East England. I know it's a much later day for you today, so I'm very grateful that you accept our invitation and you are here sharing your expertise with us.
Thank you so much, Fabiana, for the introduction and especially for the invite. And I really thank the Canadian Premature Babies Foundation for inviting me to speak with you today.
Thank you. So sorry, just for all of you watching us live, please do send your questions and we address them at the end of Dr. Clarke's presentation. So the floor is yours.
Thank you, Fabiana. So I'm going to speak today, and it's a real honor to speak in this Kangaroo Care week and series. I'm going to talk to you about the vital importance of birthday cuddles for extremely preterm babies and their parents. So I'm going to start by showing you a little animation which will set the scene.
They say from the first time you hold your baby, you will never be the same. Your life changes. The love you feel and the emotion is overwhelming. When you have an extremely premature baby, you wish with all your heart that you could experience that flood of emotion the moment they're placed in your arms. You would give anything to hold them the way you have dreamt. Most mums of premature babies don't have the opportunity. They may have to wait weeks, months, or may never get to hold their baby while they're still alive. At 23 weeks pregnant, I was expecting twins. Charlie was shown to me and taken away to the neonatal unit as I was still in labour with his brother Jack. Jack had a more difficult birth and it took some time to intubate him. This was extremely distressing for us. Once Jack had been stabilised, the consultant asked me if I would like to hold him before they took him to the unit. I instinctively knew this wouldn't be something I'd get to do again anytime soon. Holding my baby in my arms was one of the most special moments in my life. He was so tiny, so perfect in every way, and and never in my life have I been so proud and felt so much love. I was completely overwhelmed with emotion. Would any mother turn down the chance to hold their baby for the first time? Jack died from an infection after only 11 days of life. The only other time I got to hold my baby was as he died in my arms. I still find it difficult to speak about to this day, but the cuddle I had when he was born is something I will treasure forever. Jack's twin brother Charlie very nearly didn't survive. It's been a long journey to get him where he is today. He's a happy, healthy and crazy little boy with so much character. He's now 14 years old. Since the birth of my sons, I've been told that being able to hold your premature baby isn't something that every consultant offers. And to be honest, this surprises me. I needed to tell my story to raise awareness about just how much that first cuddle means as a mum. 14 years later, and this still isn't common practice.
So I'm so grateful to Emma and Charlie and Jack for allowing me to share this little animation with you, which sets the scene of what I'm going to talk about today. So I'm going to talk about the delivery room cuddle. First of all, start with the definition. What do we mean by that? It simply describes the event of a mother cuddling her preterm newborn before his or her admission to the neonatal unit, and our facilitation of this while we're providing ongoing intensive care. Many others refer to it as the birthday cuddle. It's the same thing. We're referring to the mum cuddling the baby in her arms or on her chest instead of just us showing it to her briefly. Now, to many, the delivery room cuddle may appear only a relatively trivial event, often to healthcare professionals, but it's often a huge event in the life of a parent and the preterm baby. The way we practice it, it follows that initial resuscitation and stabilization, which happen over the first 10, 15, 20, sometimes longer minutes. It's typically just before we would normally have taken the baby away to the neonatal unit. There's a precious window there where we can just take stock, the baby's stable, and the baby needs to go back to its mother. The duration as we typically practice at the moment is anywhere from 5 to 10 minutes usually, sometimes shorter, sometimes longer. It does vary depending on the situation. But we do now aim to practice it wherever and whenever possible, and we do that irrespective of birth gestation. So my talk is going to focus on the practice of trying to make this cuddle a reality for extremely preterm infants, babies born less than 27 weeks gestation. Of course, it can apply to all infants, but if we can do it safely and practically possibly for these tiniest of babies, then there's no reason at all why we shouldn't be doing it for all preterm babies. So we're now in an enlightened era of family-centred care, family-integrated care, and there's a massive evidence now showing that optimal health outcomes are achieved when the family members play an active role in providing emotional, social and developmental support. Now that active role of parents should really start right from birth for all babies, often before birth as well, it's possible. If we enable that delivery and cuddle, it's the ideal way to promote a partnership between the parents and the very healthcare professionals who'll be caring for that baby for many days, many weeks, sometimes many months from the very outset. And if we allow and permit and facilitate the mums and dads that chance to cuddle their baby before we take the baby to the neonatal unit, that begins that partnership in a really solid and constructive way, and it can have many benefits. The practice is feasible, can and must be done safely, and it's beneficial. So we firmly believe it can and should be practiced for most babies born preterm for their benefit and for the benefit of the parents. So what are the potential benefits of delivery room cuddles? Well, we already know the massive evidence behind Kangaroo Care and direct skin-to-skin contact, multifold benefits, which include physiological and behavioural benefits, psychological benefits as well. So while for extremely preterm babies, the delivery and cuddle does not usually, as we practice it in the UK, involve direct or complete skin-to-skin contact, because the baby is, in our current practice, in a polythene bag and swaddled. Nevertheless, there is some skin-to-skin contact there, maybe limited to the hands, the limbs, or the face as well. And some of the benefits may indeed be similar as to what we're seeing beneficial from kangaroo mother care. We do know, and have known for decades, that there's an early sensitive period in those very vital first minutes and hours after a baby's birth, and they're really important for the formation of a tight bond between the mother and her infant. There's probably some special imprinting that's going on in that very precious period. It's a period characterized by special neuroendocrine situation, probably mediated by hormones, oxytocin and prolactin as well. It's a unique period of increased maternal sensitivity and responsiveness. And if we can try and facilitate contact in that period, it may improve the quality of mother-preterm baby interactions and increase the chances of good bonding and long-term secure attachment. So why should we endeavour to practice birthday cuddles? Well, first and foremost, mothers and fathers, they want to cuddle their newborns. Cuddling the baby in their arms and holding them close after birth is instinctive for parents. And that goes without, no matter what the gestation is. We do know that abrupt separation and removal to the neonatal unit of a baby who's already been with the mother for more than 6 months is traumatic, and that's mutually traumatic, I believe. I only had to listen to some of those powerful testimonies for the parents last week who spoke. So Petya and Janita, their moving accounts were really striking. You know, it was days and sometimes weeks before they got to hold their babies. And it was really traumatic for parents if they're not able to hold for many, many days. They feel a real sense of grief and separation. So what we can do is provide a calm, supervised initial cuddle. It's a marvellous opportunity for us healthcare professionals to provide initial reassurance for parents that the baby's okay, for them to meet and form an initial bond with their baby, and for the baby to feel a first loving embrace. It's a special time when parents can touch and kiss the baby and get the first family photographs and first family videos together. I believe strongly there's an imperative that we must practice it for the highest risk babies, the most preterm babies. It's certainly not routine practice everywhere as yet. On neonatal unit admission, any parents listening in who've had preterm babies, you'll be only too well aware how immediately shackled and incarcerated their babies seem to be within the incubators, connected to multiple items of equipment and breathing tubes. And if we don't allow that cuddle before the baby's admitted to the neonatal unit, it's often many days, if not weeks, and sometimes months before that first cuddle becomes practically possible. So that initial cuddle is actually especially important for extremely preterm babies because they're the ones at the highest risk of dying and sometimes dying very unexpectedly. And it's a real tragedy. I've seen this from first-hand personal experience. If that first cuddle is only offered when the baby suddenly collapses and is dying or terminally ill. And I've seen in my own practice that many parents, out of sheer grief, cannot bring themselves to hold their baby in such circumstances. That's a real disaster for all, not least the baby and not least the parents, if that baby dies suddenly, never having had the chance to have a cuddle. So why is it not yet routine practice? Well, it's a good question, but we've just never done it traditionally. We've always felt that imperative to rush the baby to the neonatal unit as though that's the place of safety. But the baby's been safely with the mum for so many months. There's no reason we can't bring that baby back to the mother so the mum can meet the baby for the first time ex utero and get to know and see and love and smell and kiss the baby. Hitherto, there's been an almost absent literature, there's been lack of guidance, and there's been lack of safety and outcome data until very recently. There's been very, very few trials in this area, so very little research, and certainly hardly anything at all in extremely preterm babies. Really importantly, we've not taken the time to actually ask parents what they want and listen to what they want and need. And it's only now that we're starting to hear the parents' voice and how important the delivery room cuddle is to them. I'm pleased to say it's now becoming more and more routine practice in many UK centres over the last couple of years. Where we practice it, you can see it's unanimously supported by nurses and midwives and parents. It's been my own personal practice for around 20 years now. And I'm pleased to say it's almost daily practice in my own neonatal unit in Norwich now. Excuse me. So first and foremost, if we're going to do it, we must do it safely. So safety first. So what about the safety in extremely preterm infants? So up until recent years, there was no safety data at all describing the practice or showing its safety. And not surprisingly, many colleagues were very apprehensive about it and dubious about it. So we did a retrospective study looking at our own practice in Norwich, where it's been practiced fairly regularly, intermittently initially, but more regularly lately. And we look back over a 12-year period to look at its practice in extremely low birth weight babies and extremely preterm babies. So we looked at babies less than 27 weeks gestation who'd had a maternal cuddle at birth. And we matched those with a group of inborn babies on our own centre who we could see from the documentation had only ever been briefly shown to the parents before the neonatal unit admission. So when we compared the two groups and the time to admission and the admission observations, we saw that there was no difference really in the time of neonatal unit admission. It wasn't significantly different. There was no significant difference in the admission temperatures, and there was no difference in the mortality in these babies. We concluded that offering parents a brief delivery and cuddle of their extremely preterm baby prior to the admission did not significantly delay the baby's admission, nor did it adversely affect neonatal admission temperatures. So who should we be doing it for? Which babies? I would say most babies should be eligible and considered eligible any birth gestation. This includes pre-viable babies, babies who are born too early to ever be taken to the neonatal unit. And it also includes babies with anticipated severe congenital abnormalities where postnatal survival is not expected or is uncertain. There are certain babies where it's probably or definitely not indicated, and this includes the situations where mother's being delivered under general anaesthetic, but don't forget the fathers in that situation. It's very often possible for the fathers in the anaesthetic in the delivery room theatre to be given the cuddle before the baby's taken to the unit. If the mother's acutely unwell herself and needing stabilisation, obviously her needs must take priority. Some babies are born with expected or unexpected difficult airways or congenital airway malformations. Clearly, it's inappropriate in those cases. And also in the rare cases where there's a prolonged or ongoing resuscitation, it's not indicated. There are certain other situations where we certainly wouldn't regard it as absolute contraindication, but which poses their own difficulties, such as where the mum's having caesarean section to deliver an extremely preterm baby, but they are awake, where she's delivering multiples, either in theatre or naturally in the delivery room. And babies who've expected to have cyanotic congenital heart disease, often there's an imperative to get prostaglandin started in those babies, but there's no reason why the baby couldn't have a brief, few-minute-long delivery cuddle with its mother following the delivery. Babies are born unexpectedly encephalopathic and require active cooling. Again, a few minutes with the mother before we take the baby to the unit isn't going to make any difference at all to the outcomes there. There was hesitation previously with babies with congenital surgical anomalies, but there was a series published by Evans and colleagues from St Mary's Hospital in Manchester. They published a lovely series of babies with all manner of surgical conditions where they were able to give delivery room cuddles to. So until recently, there was no evidence to guide on the practicalities or the safety. And I must pay tribute to my colleagues, my co-first author, Dr. Paul Corley, consultant neonatologist in London, and my co-author parents, Emma Allen and Sheila Atuono, who together we wrote this paper, which was the first in the literature to describe the concept of the delivery and cuddle, its practice, and how we may do it safely. And we also got a lot of parent feedback, which is presented in full in that paper. And thanks to the UEA, my university, it's been made open access, and the link will be posted by Fabiana in the chat for anyone to download that. So in this paper, there's probably not time to go into it today, but we've described the whole process for a safe delivery and cuddle, what needs to happen before, the counselling with parents, that everyone's on board staff-wise. We talk about the birth and the stabilisation of the baby, and then the moment where the baby's been stabilised, and then bringing the baby for that cuddle if they're deemed and assessed to be suitable. We talk about the practicalities, how it can be done, and each unit will have its own challenges and should look at how it can be done safely in their own unit, but we provide broad and quite detailed guidance for how it can be done in general. Some things we've learned along the way: good communication with parents is absolutely key. It's important that the parents are properly briefed beforehand, and we don't suddenly come and plonk the newborn, extremely preterm baby on them. That'll give them shock, and they'll start to worry that we're denying the baby intensive care. So it's really important that we make sure that they're briefed properly, that they know the baby's stable and is receiving ongoing intensive care, and that the baby's going to be getting ongoing intensive care during the time that the baby's back with the mother before we take the baby to the neonatal unit. And what we always say is that there's never more professionals to hand for a single baby at any time in its life. So if any mishaps are going to happen, which we've not seen in our own practice because there's so many people around, but if the tube's going to be dislodged, for example, there's always the professionals on hand supervising it to put it back promptly. We reassure the parents that the baby will be continuously monitored and will be safe throughout. And it's really important that we offer to help the parents take photos and videos in that moment, so we can act as the photographers and the cameramen. There's plenty of people in our team that can do that for them while they're enjoying those precious moments. So really importantly is to know what the parents and what it means to them. And as I say, in our paper, we've presented lots of quotes from the mothers who've been able to experience the delivery and cuddle, and also then some of them that didn't have the chance to have the cuddle and what they felt seeing other mothers had the opportunity. So here's some of the feedback we got from 2 mums of 26-week gestation babies. So one said, making that initial cuddle as close as it could have been to had he gone to full term to make it feel normal was great. Another said it was incredibly important because I didn't get to hold my son again for 2 weeks as he was too sick. That birthday cuddle helped to initiate my breast milk, and I was able to express and eventually breastfeed my son when he was stronger. So Josie, a mother of 23-week twin girls, here are some of her reflections on her delivery and cuddles with both twins. She said, I got a cuddle with both. It was so beneficial to hear them cry and stop to have that first cuddle. It was just what we needed, as I knew I wasn't going to have another cuddle for a while. And to have that first cuddle, I felt like a mummy. I felt like a mummy. And I was very thankful because I didn't get another cuddle until 24 days later, which again was very emotional to see them and touch them. Maybe it's that first touch was what we all needed together, knowing it was going to be a really tough journey ahead. I was, and I'm so grateful to have had that first cuddle, and luckily I got the chance. I really hope this becomes the norm to have straight after delivery and get such a powerful connection you have, even at that early on time. And I feel this is part of why my girls have done so well, because of as much skin to skin as I could do from the minute I could. So I want to highlight, and thanks to this little video clip, which I'm about to share now, that it is possible, even for the most extreme preterm babies, the babies right on the border of viability, that we take to the neonatal unit. And this little clip was from a couple of years back. So July 2018, I was privileged enough to be at this delivery with Sheila and a partner who Sheila delivered vaginally a 22-week and 6 gestation boy. 530 grams. And this video clip you'll see now was taken at around 26 minutes postnatal.
Go put him back in. He's absolutely fine if you want another couple of minutes. He's absolutely lovely. He's doing a bit too well, which is why I just asked Sam to turn him down a little bit.
So it's actually there. Pull in a little. That's it.
Okay. Just now, keep it on your.
Yeah.
Okay. Just really
So what we got? We've got saturations 95.
Heart rate's 170.
Fantastic.
His temperature is perfect.
Super.
You've grown him very well, Mummy.
Thank you so much. Thank you, everybody. Thank
Very good job there. You would have been huge if you'd gone all the way.
So it's early days. So what we'll do when we get round, we need to put some special lines in into his tummy button, so we can give him some sugar solution and then some liquid feed as well.
Okay.
And then really important will be, are you planning to breastfeed? Have you thought about that?
Yeah.
That'll be really crucial. If you can get work on, overnight, get some milk expressing, and then we can trickle that down into his tummy.
Okay.
We'll be doing an X-ray to check the position of the lines.
Okay.
And then just see how we go, minute to minute, hour to hour, and so far so good. We couldn't have hoped for a better state of him to start with. He's super. And good weight as well. We'll weigh him when we get round.
Yeah, do you know?
We don't know his weight yet.
Okay.
But as soon as we get round, we'll be able to weigh him and then let you know what it is.
Daddy, did you want to stay with Mummy, or did you want to come across with us?
I stay with you. Yeah, you're going to be fine.
We'll be doing lines and bits, but you can all sit with him and we can keep you updated.
Talk to him.
To talk to him.
Telling you bad jokes.
See, Mum's not lost his sense of humour.
Oh my god, yeah, bad dad jokes.
It's just part of being a dad. Welcome to join that club now. Bad dad
Finally, I have an excuse.
Dad dancing.
So, sincere thanks to Sheila and her partner for allowing us to share that with you. I hope it gives a sense of how peaceful it is in the delivery room at that moment. So he'd been stabilised, the tube was in, I think it slipped out and was just put back in. So that was taken when we brought the baby over to her, and he must have spent a good 9 minutes on her chest there before we took him to the neonatal unit. I think the dad had about 4 or 5 minutes cuddle as well. And I remember asking Sheila, when did you next get to cuddle Nicodeme? And she said, day 38. So this is the reality. If we don't try and facilitate that cuddle early on, it's going to be weeks at best before these tiny babies ever get a chance to be with their mums again. And Sheila's words reflecting were, considering how unclear the outcome of his birth was, I can honestly say that cuddling Nicodeme was probably the most encouraging factor in me deciding to express milk for him. Another reason delivering cuddle is vital for these tiniest of babies is because, sadly, as we all know, some won't survive. So I'm sharing this little clip with you now from May 2021. So 2 years ago this was, and this is Constance, and shared with her kind permission. And this little girl was born at 22 weeks and 6 days gestation, 460 grams. And this very brief video clip you'll see was taken on Connie's phone when Sophie was 20 minutes postnatal.
Yeah, lovely. So it's much warmer than that in here, isn't it? Yeah.
It's okay. Take good care.
When you're feeling up to it, you can come and visit her.
Okay, so how do I identify her?
Well, we know who she is. So we'll tell you when you come over and we'll point you in the right direction. You don't have to guess, it's alright. Yeah. And that's where she'll stay, in the space where you put her. So you know where she is. She's on the dermis, baby.
You can take her.
Okay, you ready? Oh, that's lovely. Good girl, Sophie.
So Constance's words were, I and my husband are most grateful for the opportunity of had that birthday cuddle and lack words to appreciate you enough for taking those pictures and videos. They are forever cherished treasures of her sweet memory. It serves as a means to alleviate our pains on those bad days or the highest moments of our grief and making those days feel better. The short period of cuddling is better than none at all. If life presents such unpredictable situations, it creates lovely or even happy moments to cherish in future. One of the pictures you've took is the only and closest shot of her beautiful pink lively face before she became poorly days after. And sadly, little Sophie died about 2 or 3 days later on our neonatal unit, fairly suddenly and unexpectedly. So there's no doubt about it that the birthday cuddle is emotional. So in this final clip from a parent and little baby I'm going to show you is from almost exactly a year ago. This is a 24-week gestation baby, 500 grams. This is baby Hannah and her mother, Dasha. And this has taken about 25 minutes postnatal. So baby's been stabilised. This is a little 24-weeker who had Luisa.
Oh, you're doing so great, aren't you? Hey, gorgeous. Oh. Hi. I love you so much. I love you so much. I love you so much. Me too. Oh. Oh. Oh, I love you so much, baby. I love you so fucking much. You're the cutest creature in the world.
Okay.
I believe you. If you don't, I'll chase you.
So I apologise for those who couldn't quite understand the local dialect, and apologise more for those who could. But thank you to Dasha for sharing these amazing photos and videos with us. So I just heard from Dasha yesterday. She said, I'm not going to lie, I'm tears when I look at them videos, and I'm so grateful for letting me have that cuddle. I think it made a huge difference, gave me hope and motivation to fight for her. And little Hannah will be 1 next week. So thank you, Dasha. Thank you, Hannah. So that birthday cuddle, it really is irreplaceable. You heard from Emma in her animation to start with, and I'm so grateful to Emma. She's been with me from the outset in presenting these data and presenting the concept ever since 2018 when we first presented it nationally in the UK. These are her words. A cuddle is so important. Being able to hold Jack right after birth, it meant the world to me. It was so special. It's the hardest thing in the world not having your baby near you after delivery, and you hold on to that one cuddle that you've had. The cuddle I had with Jack when he was born meant so much, and all mums should have this opportunity. Thank you, Emma. So I'm going to end by, final clip is again from parents. Without hearing from parents, you just need to hear from parents if you're in any doubt the importance of the cuddle. So let's hear from Lottie. Lottie runs a charity up in the northeast of England called Leo's Neonatal. She does a lot of great work looking at helping preserve the mental health of parents who spend time on neonatal.
As part of that, Aaron Leo's, we are a charity which supports the mental health of families who have been through a neonatal stay based up in the northeast of England. I've got a first-hand lived experience of being a parent without a delivery room cuddle. I'm a bereaved mum as well, so I had twin boys, Leo and Oscar, back in 2015, and sadly Leo passed away at just 4 hours old in the NICU. And I came across the delivery room cuddles a couple of years ago on Twitter and immediately got in touch with Paul because I just thought, oh my God, this would have changed so much for me as a parent, because I was and always will be the parent that the first time I got to really see and hold my child was at the point in which I was told he was dying. And the impact on me was so catastrophic because no one ever thinks as a parent, when you get pregnant as a woman, you don't ever think that your baby's going to die, let alone that you would hold your child while they were dying. So for me, kind of, this is so important because it can change the trajectory for so many families, not just the bereaved families, but also the families that go on to have surviving, babies in the NICU. Speaking again from my own experience of having a surviving twin with Oscar, I didn't get to hold him for over 2 weeks, and it massively impacted the bond that we had because I looked at him for so long like a patient and not as my own baby. And I think if there's anything that teams can do to help facilitate these cuddles, it absolutely, in my opinion as a parent, it should be done, because when you are handed your baby for the first time and told the words that your child is not going to survive, here you go, I cannot begin to explain as a parent the devastation that causes. And to be wanting to have that moment with your child, as we often see when we walk in maternity wards, the mum with the baby on the chest or breastfeeding, and it's kind of drilled into you all the time that that's how your first moments should be with your baby. And when that isn't the case, the pain is indescribable, and it's not something that as a parent, as a team, that you can ever go back and have a do-over. So it is vital that if you can offer those cuddles in that situation, then you absolutely should be, because you have the power to change the trajectory of someone's grief. Losing a child in the NICU is a very unique experience that comes with a lot of trauma. But if there's something that can be done, beforehand in that delivery room to help facilitate, a lovely moment, a moment that allows that family to feel like a family, a mum to feel like a mum, a dad to feel like a dad, you know, and that family to be united, I think you should, you know, absolutely 100% do it. I can't advocate for it enough. It's something that we absolutely love at Leo's, and yeah, I just think it's wonderful.
Thank you so much, Lottie, for saying it so eloquently. You've summarised it up so well. You have the power to change the trajectory of someone's grief. We have the power. So in conclusion, you've heard it from the parents themselves, say it far better than I ever could. But this is why we need to practice it. It's very safe with appropriate preparation, supervision, attention to detail and teamwork. We've published now how it can be done safely and should be done safely and introduced safely. Good communication between all is the key to success. So when we talk about birthday cuddles, the reality is we really only have one true birthday in our lives. So we only have one chance to ever offer that birthday cuddle. The delivery room birthday cuddle is hugely appreciated by parents, and not least those who will sadly end up as bereaved parents. The delivery room cuddle is feasible for the majority of preterm babies, irrespective of gestation, and it really should be the norm and not the exception. So I can't give any talk on this subject without acknowledging many people without which we wouldn't have ever made any progress. I must offer sincere thanks to all my nursing, medical, midwifery and obstetric colleagues in Norwich for their huge support in making this everyday practice now in our centre. I'm indebted massively to Emma, Sheila, Lottie, Connie, Dasha and all their babies and their partners for kindly sharing these videos with me and thereby with you. Huge thanks to my co-authors, Dr. Paul Corley and Emma and Sheila, for their enthusiastic support, co-authorship on the paper, and development and promotion of delivery and cuddle practice. Thanks to all parents included who've kindly allowed us to share their pictures and words. And thank you to all for joining today. I'm very happy to answer any questions. Thank you.
Oh, Professor Clarke, thank you so much for your presentation. I'm not gonna lie, I was crying watching those videos because I wish I had the moment when my son was born at 26 weeks. So it's very emotional also because it's the week that 11 years ago I was actually going into labor and stopping labor this time in my life. So it was very emotional to watch those videos, hear those stories. And I also wish I had the moment with my son because it also took me a few days to be able to actually hold him after the delivery. So my first question to you is, how do you change the culture in your hospital with your team to enable cuddles to happen?
Well, I think we've got the resources now. We've got the publications as professionals there. They are there. It's freely downloadable. As I've said, ours was the first paper to describe it, and it's really important information in there. Again, I thank Dr. Paul Corley for making the safety aspects, the practicality aspects a reality. I think we just have to listen to the parents. How could any professional hearing these parents speak not want to change their own practice and then strive to do it? You've said yourself, Fabiana, what a hole it's left in your heart not having had that initial contact. Any parent who's been through that, we just need to listen to parents. I've no other answer really. The way to go about it, again, we've published how to do it. You know, we can do it in scenarios, get the team on board, have champions. It's all there, it's all published, and yeah, we just need to listen to parents, what they want and what they need.
So do your teams work together, obviously, with the obstetricians? Because, you know, it feels sometimes there's a disconnection between the obstetricians and the neonatologists. And do they talk? Do they come into agreement? This is the best for the baby or for the parents on the long term. So how is that conversation happening among different teams?
I mean, it's gradually increased, I must admit. You know, it was sporadic initially, but now it's common and it doesn't faze them at all. There needs to be education of obviously the whole team through the midwifery champions, present it to obstetric colleagues. If we're in the room, like I remember with Nicodemus delivery at 22 weeks there, we had to, and it's only the right thing to do, to ask the obstetrician, was he happy if we brought the baby to the mum? Had he finished dealing with the mother? So there's important communication between the teams there, even if they've never seen it before and it's alien to them. But once they've seen it, you know, they cannot fail to be impressed by how important it is for the mum and for the baby.
Absolutely. So my last question to you is, do you talk to parents prior to the delivery about the cuddles, what's going to happen, how is the baby going to look like? Because I was in shock when I actually saw my son in the NICU 2 days later. I didn't see him at the delivery room, how that tiny baby looked like. So do you have this conversation prior, and you ask the parents about the cuddling? Do they want to do the cuddling, or how do they feel about it?
Well, I don't so much offer it, although which parent wouldn't want the chance to hold their baby? I think as long as we've explained to them what it's all about and that the baby's safe and is getting ongoing intensive care and it's the safest place the baby will ever be. In many ways, as I've said, there's so many staff around there. There's so many who can attend to the baby and carry on the intensive care and the monitoring of that baby closely. We're blessed with lots of non-invasive equipment these days. You know, only recently have we tested wireless heart rate monitors on our unit. We routinely place a probe in the axilla, so we're watching the baby's temperature throughout, so we can monitor that. We found that the babies actually maintain the temperatures better when they're on the mother, which is not a surprise really. The mother's at the right temperature for that baby. So we're blessed with all that non-invasive equipment, and I think you had some insight there into all the monitoring we were doing while the family were enjoying the cuddle there with nicotine. We were very well aware of the heart rate, saturations. Yeah, so I think with close attention to detail, it is absolutely safe, should be done. You know, there's a precious window there. The baby's lovely and stable. You only have to see those babies with the mums. They're so peaceful. You know, it's not like a day or two later when things might be deteriorating, the fluid balance is all over the place and the baby's ventilation's got more difficult. It's a really precious window that we're blessed with, and we should use it.
One thing that caught my attention on the videos is how quiet and calm the room seems to be. Because every my delivery room seems very chaotic and loud, or maybe that was my perception of it. It seems so calm and soothing. It really caught my attention, those videos, to see how that beautiful moment was unfolding for the parents.
Yeah, thank you for that. I'm glad you noticed that, because that's how it feels. It's a really lovely, peaceful moment. The stress of, are we going to get a tube in? You know, what conditions the baby going to be like? Our heart rates are racing as well. That's all past. The baby's stabilized. We're as happy as we can be with that baby. So we can relax as well, and we can relax and enjoy those moments. We're in a very privileged position to be right there with the family. We should help them with that video. Get some lovely little video clips that they can love later, and it'll help the mum to express in those early days when she's away from the baby, replaying that video. So yeah, there was one clip with a lot of beeps on, which we didn't notice at the time, but you know, that also makes us reflect on our practice. All those beeps going on, which in retrospect it interrupts it. But yeah, peaceful moments.
It's beautiful. Okay, Professor Clarke, thank you so much for joining us here today, for sharing your knowledge and experience and expertise. And I do hope many units adopt this care around the world, because it's so important. And I mean, we hear the parents, we heard the parents, how important it is and how much they cherish those moments. So thank you so much for being with us today.
Thank you, Fabiana. Thank you all.
So we're going to continue our special edition of Kangaroo Care. We all know that the contribution of Kangaroo Care to the stabilization, regulation, growth, and neurodevelopment of the preterm infant is well documented, and its benefits for the infant are profound. However, let's recognize the significant effect of skin-to-skin contact in the reduction of stress and the resulting benefits to both infant and parent in the area of mental health. This presentation reviews the effect of the NICU experience on the mental health of parents and their infants, and explores the positive impact of Kangaroo Care on mental health outcomes of parents and babies. Luisa and Beth will also share their experience of creating and running a NICU Kangaroo-a-thon to encourage and enhance the practice in the NICU. And I have here joining me live from Toronto, Luisa King and Beth Nelson. Luisa is a nurse and lactation consultant working a level 3 NICU for over 30 years. Currently, she serves as the Breastfeeding Resource Nurse and Developmental Care Coordinator for the NICU at the Sunnybrook Hospital in Toronto. In this role, Luisa is able to serve families from several different perspectives, supporting parents while they learn how to respond to their tiny infant in developmentally supportive ways, building and protecting their milk supply, and eventually helping them on their feeding journey. Her personal high comes in helping a parent experience that first kangaroo cuddle and observe the transformation from nervous onlooker to love-struck parent. Luisa, wave so that we know who you are. Thank you. And next to her is Beth, who is also neonatal nurse and lactation consultant, who has worked in the level 3 NICUs for over 35 years. She presently enjoys a dual role as breastfeeding resource nurse within the NICU and as a lactation consultant within the Sunnybrook Hospital's breastfeeding clinic. This joint role gives Beth the opportunity to use a broad range of skills as she cares for the fragile preterm baby and the more robust term infant and family. Her greatest joy is seeing moms meet their breastfeeding goals and in seeing parents develop confidence in their parenting. Thank you so much for joining me here today, joining this incredible session on kangaroo skin to skin. It's such an important topic, and I'm so grateful you accept our invitation to be here today.
Thank you. Thank you.
So I'm going to share to bring your slides up, and then to all of you watching this live, please do send your questions, comments. We'd love to hear from you, and you can address your comments after their presentation.
Thanks so much, Fabiana, for inviting us today. Well, this is a huge topic, and we're trying to compress it into a 20-minute talk. So we're going to be moving quickly through our slides. We're going to be really trying to touch on the mountaintop, key aspects of our focus on mental health and kangaroo care. So hold on to your hats. We're going to move fairly quickly. We have nothing to disclose. Our objectives today are to explore the ways in which mental health is impacted by an NICU stay and how this impact is reduced by kangaroo care. We're also going to explore strategies for using kangaroo care within the NICU. All humans are made to connect with others. In fact, we are wired for connection through our physiology. At birth, and Dr. Clarke mentioned this a little bit, there are specific hormones that influence our ability to connect with our babies. And we're going to talk quickly about those. So in the laboring dyad, the act of giving birth triggers a hormonal cascade that influences the mother and enhances the neuroplasticity in her brain. These hormones selectively influence regions of the brain to help the mother become more responsive to her baby and help with her caregiving, to facilitate and trigger the release and continued production of her milk supply, to develop synchrony with her baby, heighten her protective instincts towards her infant, diminish her stress, and create a feeling of love, well-being, and connection. For the father, he also experiences a triggering of many of these same hormones, especially after he's had a skin-to-skin cuddle with his baby. And they result in different responses in his brain toward both the baby and his partner as well. These hormonal influences affect more paternal responsivity to the baby, increased proximity seeking towards his child as well, synchrony between the baby and also between his partner. And as with the mom, it creates a feeling of well-being, love, and connection with his baby. The baby also has hormonal responses because of his birth. These responses stimulate physiologic processes such as his breathing and sucking. It elicits pain control, which allows the baby to be more alert and calm and ready to connect with his mother. It heightens the sense of smell and hearing, which allow the baby to seek out and engage with his mother, especially in the area of breastfeeding. It reestablishes stability in an infant who's been stressed by the birthing process. And particularly as that baby comes to his mother, the mother also helps to regulate that in her child. We have seen that when birth follows its normal course, including labor, delivery, and the immediate connection of the infant and child, the infant and the parent, hormonal changes contribute to a healthy bonding and attachment, as well as physiological regulation. So what happens when this normal course is changed by the arrival of a preterm baby? In this situation where the infant is whisked away from the parent and where parent-infant separation may stretch from hours to days or longer, as you've also heard, this process of attachment is delayed. Furthermore, for the expectant family, the untimely arrival of a fragile infant brings with it fear, uncertainty, and stress, impacting the mental health of both the parent and the infant. Today, everyone is talking about mental health, so it is important to define what we are meaning by this term. We have borrowed from the succinct definition from the World Health Organization. In their understanding, mental health is equivalent to experiencing mental well-being. This definition also recognizes the impact of mental health on the individual's ability to manage stressors of life, as well as life in general. But what about the infant mental health? This definition here comes from the Vanderbilt University's Center on the Social and Emotional Foundations for Early Learning. And it describes a healthy picture of a growing infant. Positive infant mental health means that the infant grows in its ability to regulate him or herself and to develop a relational attachments with others. This allows the infant to move forward, developing social and emotionally into the preschool years and beyond. Those NICU moms who may be listening to this presentation probably can recall experiencing the long-term and possibly unrelenting stress, anxiety, and fear while your baby was in the NICU or is in the NICU. These experiences contribute to significant levels of postpartum depression, acute stress disorder, and post-traumatic stress disorder in the NICU mom. Notice these rates. Compared to mothers of full-term infants, for instance, where the rate of postpartum depression is 1 in 5, the incident rate increases to 1 in 3 for the preterm mom. Additionally, they are subject to higher incidence of acute stress disorder and post-traumatic stress disorder than their women in the term infant population. This is often related to the traumatic birth experience and the long-term separation from their infant. For NICU staff that are listening to this presentation, what faces come in mind of family members in your unit that likely are experiencing one or more of these conditions? Being aware of risk factors for mothers is important as it can identify more vulnerable women, leading to better support earlier. Many mothers in the NICU are also at increased risk because of the multiple risk factors they experience, as shown on this slide. The highest risk factor for developing postpartum depression is a prior history of depression. We include this image of an ostrich as it illustrates common ways in which fathers tend to avoid admitting mental health issues. Fathers often either fail to recognize it appropriately, calling it stress, or they may try and deny it. 5 to 15% of fathers experience anxiety and or paternal perinatal depression, the symptoms of which are often delayed, most commonly occurring between 2 and 3 months after the birth, which makes it all the more surprising and unexpected. Themes that emerge in the research that fathers report having, they explain that they do not feel entitled to mental health supports and the focus should be on the mother. They feel stressed, which is expressed by exhaustion, poor concentration, and irritability. They need to support their partner, protect their relationships by maintaining financial support, home tasks, sibling care, and not stressing the mother. All of these activities take them away from the hospital. Any NICU dads that are in the audience recognize these descriptors in their own experience? Any dads come to mind for NICU in the audience? As with mothers, awareness of the risk factors that make men more vulnerable are important to monitor. Generally, the NICU tends to focus on the mother and the infant, and they kind of relegate the father sort of to the corner and they do not consider his mental health. We need to remember that the birth of a baby may mark a transition to fatherhood. Fathers play an important role in childhood development and their child's sense of well-being. So we need to consider when we're doing our consults, is there a mental health history of the father? Do we provide peer support for fathers? Do we provide social work and psychosocial support to fathers as we do the mothers? There's a large amount of literature regarding parent mental health in the NICU and beyond. For the sake of time, we have distilled the information down to essential impacts of impaired mental health on both parents and the child. Parents who experience impaired mental health are often less responsive and interact less with their infant. This impacts their ability to enjoy healthy communication and caregiving practices towards their infant. The parents' impaired mental health and corresponding behaviors reduces attachment and bonding and significantly increases the risk of child developing a mental health disorder in their future. So far, we've presented a fairly overwhelming and sobering view into the reality of the experiences and lives of families in the NICU. However, all isn't lost, and there is much we can do to reduce the impact of stressors for families in the NICU. In this quote, Mary Coughlin points to the importance of positive experiences which help to build a healthier infant brain. I want you to stop and think for a moment about the common experiences of babies and their parents in the NICU. How many of the interventions that babies receive in the NICU support these neural pathways related to security, connectedness, attachment, self-regulation, and love? More often than not, the neonatal experiences are related to things such as isolation, separation, pain, trauma, intrusion instead. So the question then is, how do we support families to become empowered parents versus onlookers when it comes to the care of their baby? And also, how do we facilitate a return to practices that support these positive experiences? We propose that Kangaroo Care is a relatively easy solution that supports healthy connection and improves mental health in both infants and their parents. So we're going to switch gears just a little bit now and review some of the ways in which this is true. And then we're going to go on to talk about how we can increase the practice within the NICU. In our minds, there are 4 pillars that underscore the need for Kangaroo Care as standard practice within the NICU. While all of these pillars are important, we're going to focus only on that last pillar, that of improving mental health outcomes for families. We're going to look at the mum. The evidence is clear that Kangaroo Care is vital for facilitating healthy relationships between the mother and her infant. During Kangaroo Care, the mother experiences a rise in oxytocin and a drop in the stress hormone cortisol. This results in moms experiencing improved attachment with their babies, less worry about their infant, a more rapid decline in the depressive symptoms than moms who do not practice Kangaroo Care as much, and overall less stress. We see this lovely quote at the bottom of the slide that really gives us a glimpse into the longing of a mother's heart. We've included a couple mothers' perspectives here. The first one says, "When I held my baby on my chest for the first time, it was the greatest thing that words can't express. From then onwards, I lived in the moments to hold him skin to skin. Every day that my son was in the NICU, I held him. It was the greatest experience." Another mom says, "Kangaroo Care helped me to get to know my baby. It gave me, as a parent, a sense of purpose in my child's life. After birth, it seemed surreal that I even had a baby. Kangaroo Care helped me to realize that being involved in all aspects of my daughter's care made a big difference for me. It helped me to learn so much on how to handle and care for my very small baby. It helped me to have the confidence I needed to be involved." In terms of fathers, they also are powerfully connected to their babies through skin to skin. When dads kangaroo their babies, they also experience hormonal changes, such as an increase in oxytocin and vasopressin. And these changes improve their level of responsiveness to their baby, resulting in a more synchronous interaction and improving the child and infant relation, or the parent and infant relationship. Fathers that enjoy skin to skin are more engaged with the entire family unit. Several studies suggest that early skin to skin contact with the father, especially in the first 3 days, enhances the effect of oxytocin on the male brain, and that causes deeper connection with the infant. These early caregiving behaviors result in fathers being less stressed and anxious, better infant and parent interaction, and allows fathers to take on a parenting role. In some studies done by Feldman, she demonstrated that long-term increases in oxytocin in the fathers will happen when they engage with their babies more consistently. So reconnecting infants with their fathers is something that we have to be intentional about. Generally, as we've said before, mothers are the ones who are given priority around holding, but fathers can't be forgotten in this important intervention. Dads, as well as moms, should be offered frequent kangaroo time with their babies. Let's look at a dad's perspective. He says, being able to touch and or hold your baby is so important, and especially so to a preemie parent. Our journeys are different than most, and when your baby is born early, you may not have time to wrap your head around how the birth, caring for baby, and a hospital stay might be different than you envisioned. Kangaroo care is crucial for babies to grow and develop. And I love this last line. It is also medicine for the souls of parents. So let's look at the effect of kangaroo care on the baby. We know that it positively impacts the infant, particularly in terms of physiologic stability for the baby, but it also improves neurodevelopmental and mental health outcomes for that child. While babies can't give us their perspective in words on what it feels like to be held, we can look at some pictures that give us that idea about how babies are managing things when they're held. These pictures of the monitor were taken by a father who didn't believe that kangarooing his baby would make a difference for his child. So he videotaped the monitor while his baby was in the incubator and then while being kangarooed. Look at the picture on the left. The green irregular heartbeat at the top and the blue labile oxygenation saturation reflect infant stress. This was when the baby was in the incubator. Now look at the way in which the heart rate and the saturation stabilize. This was when the baby was being held skin to skin. Then, as we move to the right picture, we can see that the irregularity of the heart rate and the saturation return when the babies return to the incubator. From these pictures, we can infer how the baby must be feeling. In the parent's arms, tucked in warm against the parent's chest, the baby feels secure and safe from the world of the NICU. The baby's stress level drops off, he relaxes, he's able to breathe more easily, and he settles into a healing sleep. Once this father observed the difference that kangarooing made for his baby, he was converted into a kangarooing dad.
We are curious about the prevalence of kangarooing across North America, but when we looked, we could not find any documentation of kangaroo care hours in the literature. What we did come across is a survey from 2002, in which 84% of respondents report that they did practice kangaroo care. But the question asked only if they practiced kangarooing. There was no documented amount or length of kangarooing hours done. Respondents also said that 87% of the kangarooing that was done was at the request of the parents and not initiated by the NICU staff. Only 32 hospitals out of 440 that practice kangaroo care offered it on high-frequency ventilation. Neither the Vermont Oxford Network nor the Canadian Neonatal Network collect stats around the implementation and practice of kangaroo care. The question that baffles us is why? If it is perplexing to us that a practice that is safe, easy to do, inexpensive, and proven to have significant impact on the physiological stability, the rates of sepsis, long-term outcomes, mental health, cognition, and so on, have not been taken sufficiently seriously by the medical establishment as to warrant a statistical monitoring. The survey from the previous slide demonstrates that much is still left to do when it comes to elevating the practice of kangarooing in units across the world. In our NICU, we wanted to highlight the value of kangaroo care for both staff and family. While hoping to influence a cultural shift regarding kangarooing, we did not wish to overwhelm the staff with just another project. Our goal was to embed kangaroo care as standard practice. And to get there, we decided that we needed to have some fun. So shamelessly stealing from our good friends at Helen DeVos in Michigan, we latched onto the idea of a kangaroo-a-thon. Our first kangaroo-a-thon was in 2013. We planned a 2-week intensive focus on kangarooing, in which involved parents, nurses, doctors, and the RTs. While we wanted to highlight the creative and fun ways to increase kangaroo care within the NICU, we also wanted to provide staff and the parents with education about the value of skin to skin, and to empower staff to be able to get babies out and parents to ask for it. Having a strategy to implement practice change and support from key stakeholders in your unit is central to the success of your plan. Education is very important to help people understand the why we should be doing this and the immediate and future repercussions and benefits of kangaroo care. Strong advocacy is essential to empower and challenge resistance. Teach parents to advocate for themselves. For instance, instead of, "Can I hold my baby?" suggest to the parent, "When's a good time for me to hold my baby today?" This empowers the parent to collaborate with staff. Another thing is to identify kangaroo champions within the unit to help support efforts, and this is an invaluable strategy. Preparation is essential. Parents need to understand that the expectation of extended holding for kangaroo care is important, and come prepared physically. That means they've eaten, they've gone to the bathroom, they've brought their water bottle and maybe a book to read. Staff need to collaborate with their teammates to ensure that they have support taking the baby out. It is essential that the process is smooth and controlled. There is no such thing as too much communication and organization in ensuring it is a positive experience. We began the Kangaroo Challenge as a way to share our learning and reach out to our partner units and hospitals within Ontario about kangarooing. What began as a small venture exceeded our expectations. In the following years, we threw the challenge wider and it became a global event. By 2019, over 130 units from across North America, Australia, England, Ireland, Scotland, Israel, India, and beyond joined to celebrate kangaroo care with a massive kangaroo-a-thon. Not only was the Kangaroo Challenge about some friendly competition, but it was also a wonderful collaborative event that brought NICUs from around the world and their tips and strategies for encouraging kangarooing. We reviewed kangaroo care as a pocket-sized pick-me-up for the infant and the parent, and today we have explored how this is true, especially in the area of mental health. But let's take a long-term view and remember that not only does kangaroo care impact this child and these parents, it impacts future generations as well. Epigenetic changes that occur due to trauma and poor mental health have potential reach far down the line to generations to come. In Kangaroo Care, we have the opportunity to impact future families for good. As we facilitate attachment, regulation, and synchrony, while significantly downgrading the effect of early hospitalization. This cannot happen, however, except for everyone pitching in to make it happen. Increasing kangaroo care within the NICU truly takes a team. It requires that both parents and staff work together to educate, advocate, and encourage the prioritizing of kangaroo care within your NICU, which in turn will contribute to the flourishing of infants and their parents. We thank you for your time, and we're happy to answer any questions you may have.
Wow, thank you so much for sharing all that information with us today. The Kangaroo-a-thon, I wish was back full on, because it's such a fun thing to do and really engage the teams around the world. I think my first question to you is, what are barriers? We have all this evidence, which is mind-blowing how much evidence, short and long-term impact of kangaroo care we have for the babies, for the parents, for the fathers. Why are you still facing barriers to this day in Canada to implement a culture of kangaroo care across all the units?
That's a really good question. That's our question. I think that some of the barriers are, particularly right now, there's staff shortages. There's a lot of new, for our unit specifically, we have a lot of brand new staff and they're just learning the ropes. So there's a lot of discomfort. But there's lots of excuses. It has to come from a cultural change. It has to be an expectation within the units that this is what we do. Just like we would never think that we're not going to give an antibiotic, for instance, or we wouldn't put an intravenous in or ventilate a baby. We should not be thinking about whether or not we should be taking a baby out. So I guess the best strategy is in the power of the parent. And that's how we kind of gear our focus. If you have parents that are empowered to say, when can I? What is the barrier? It becomes harder. It opens a conversation for staff to have a dialogue, and it lays the question bare. So I think it's just takes time. We're a lot better than we were, I think.
Absolutely. And now I will share with you a little bit of my experience, because my son was intubated for quite a long time, and I didn't hold him for a few weeks. And it was another parent who said, why you haven't heard your baby? I said, because my baby's on a ventilator. She said, I hold my baby on ventilator. So I asked the nurse, can I hold my baby? And from that day on, every day, the nurses made sure I held my baby. Even when he was on the high frequency one, on the test, that he was, I think I stopped breathing because I was so nervous bringing him out the incubator on that ventilator. But that was a game different. But I had to ask, right? And I think, like, what about if the parents don't know if they can ask? I didn't know I could ask, right? It was the early days of my NICU stay. Very different after when I joined the family integrated care study. But in the beginning, when I was still learning the NICU, I had to have that initiative and ask the nurses. But not all parents are going to ask. Right. And I think sometimes we give so much of, like, parents have to initiate, but we don't know what we don't know. Also, we don't know the benefits. It's just something you want to feel good holding your baby, which is a natural thing to do. But I appreciate all the information that you gave. And I'm still, as an organization, we really advocate for kangaroo care, skin to skin, because we all know the evidence and we are parents. So, of course, we want other parents to experience that. Right. And we know the long-term outcomes. What it really got me is the father's experience. We don't talk about the fathers enough, right? As a very mother-centered way of caring. And the parent, and as you mentioned, the fathers do have a higher risk of mental health issues. But how do we engage fathers, because it seems that all NICUs, not only in Canada, around the world, just struggle to engage fathers, to bring fathers to support groups or any groups, to get him to talk. So how well are you doing, and you think what we should be doing to engage more fathers in the care of their babies in the NICU?
I think it's partly a mind shift for staff to recognize the importance of the father and to see where we are missing the opportunity to educate the father and bring him in. And it's not uncommon. I'll walk into a room and the father's in the back of the room, far away from the isolette, right? And just the invitation to come near, touch your baby. Yes, it's important that you are here with your baby, and educating the father as to the importance of his role, I think, is one thing. So education for the staff, education for the father, but then really encouraging the father to take that step of holding the baby, because often they will defer to their partner. And you want to really, there's times we've both had to say to a dad, no, we're going to do this. This is really important. And sometimes it's fear, right? That he's really afraid to do it. But once he's had the experience, usually then they're good to go from there on in, right? So I think it's sort of a wide thing, both speaking to the father directly, but also having the staff aware that this is a blind spot that we have and that we can do better is really important.
Wow, that is incredible. Thank you so much for the amazing work that you're doing, and encouraging your teams to continue doing Kangaroo Care, not only in Canada, but around the world. So thank you so much, Luisa and Beth, for joining us here today to help us raise awareness of this such an important practice for our babies and our families. So thank you.
Thanks for having us.
And last but not least, we have our last speaker of the day talking about why neonatal hypothermia is such a hot topic. So Mary Kies will talk about thermoregulation, a topic she wishes she knew about as a mom, that she later learned from working labor and delivery, and that every mom should know. And I have here join me live from San Diego, California, Mary Chiesa, who has dedicated her life to neonatal safety and patient advocacy. She worked in labor and delivery for over a decade as a first assistant in the operating room in California. From this experience, Mary became aware of the many changes needed in neonatal and maternal care in order to enhance safety and meet the standards level of care. She then became an inventor, creating a medical wrap, which now is the main product of the company she founded in 2017, Saplacor. Her goal is to improve the way we care for mothers and babies, with an emphasis on neonatal hypothermia, skin-to-skin bonding, maternal mortality, and breastfeeding rates. Mary, thank you so much for joining us here today. I'm so grateful that you are here from the other side of the world. We had Dr. Paul Clarke from England and you from California. So it's such an important topic that affects us all around the world. So thank you for taking the time to be here today.
Oh, Fabiana, thank you so much for having me and to be part of this. I appreciate it.
So, and to all of you watching us live, just a reminder that you can send us your questions, your comments, and we will address them with Mary at the end of her presentation. Mary, just before you go, I really want to share a comment that came to us earlier on today from Kimberly. Absolutely. That she said, hubby and I love and look forward to Kangaroo Care when you go to an ICU at the Royal Alexandra Hospital. Just a little reminder on how important it is for both families, for both parents to be in the units. And you just know some hospitals still have restrictions with both parents. But Mary, the floor is yours. We're going to address your comments and questions from our live audience after your presentation. Go ahead.
Thank you. So I just wanted to bring some attention and to help people understand why neonatal hypothermia is such a hot topic. You know, one of the things, there's quite a few things that I wish I had knew about hypothermia as a mom that I learned later on. I had two daughters that were both preemies, low birth weight, and they're just things that I wish I would have known. One of the things was that I had no idea that newborn babies couldn't shiver. that newborn babies can't maintain their own body temperature until they're well after the age of 1, because their hypothalamus hasn't been properly developed. The second thing was probably about anesthesia. I feel like, I wish I would have known that whether you get a spinal or an epidural, that anesthesia does have an effect on not only your thermoregulation, but baby's thermoregulation. And just the facts that moms can't maintain their own body temperature. And then one of the third things is what we used to call was the baby's first ice bucket challenge. And that was our C-section babies. And then the other one was just the phenomena of mom's breast and the skin to skin, and being able to change temperatures in each breast, depending on one baby or if you have twins on your breast. And that's called thermal synchrony. And I'll go a little bit more into that. I love this one. It's like, no one told you I can't shiver. Just because so many moms that we talk to today, they say, I had no idea. I thought if my baby was cold, that my baby would shiver, or that I could tell that my baby was cold. And so, one of the things that newborns, they lose heat through conduction, radiation, convection, and then also evaporation. And we use different methods in the hospital and at home to basically conduct that. And, when you look at where the WHO, says that hypothermia is at 97.7 degrees, anything below that doesn't seem very low. And unfortunately, a lot of newborns under the age of 28 days, especially preemies and low birth weight babies, experience this and creates morbidity and mortality. As a matter of fact, admissions for hypothermia is significantly associated with prematurity. And one of the things is, even in C-sections, it's almost a man-made environment. So we have these babies that are used to being in a 98.6 environment that are being delivered into a cold operating room. Some of the things that you start to realize with babies and the size and the dimensions of babies is they're kind of shaped a little bit more like a T-Rex, right? Versus an adult. They've got this big body, this big head, and these little teeny limbs, both arms and legs. So, and their body surface is about 3 times greater than an adult. Why is this important? And it all comes back to the thermoregulation. And babies lose their heat 4 times more quickly than adults. In fact, one of the craziest things is that like 40 to 45% of body heat is lost through the head and the neck due to the increased blood flow compared to the rest of their body. So one of the biggest things with anesthesia and the effects of thermoregulation is that when the operating room is set at 65 degrees, no one ever really thinks that that's 25 degrees below what the World Health Organization's severe hypothermia standards are. When we look at normal body ranges for a baby, in utero, it's right there at that 98.6 degree temp. And then once we get down to about 97.7, now baby is cold stressed. This is cause for concern. And then once you start to seek danger is right there at that 96.8. And then severe hypothermia, which is urgent need, is at 89.6. So when mom is given an epidural or any kind of spinal anesthesia, it opens up the blood vessels and creates this vasodilation to the skin. So as a result, the anesthesia increases the blood flow to the skin, which increases heat loss. So if mom receives anesthesia, right, whether she's having a spinal or an epidural, and she can't maintain her own body temperature, how is she supposed to be the heat source for baby immediately after birth for skin to skin? And, the bear huggers that we used to use in the OR, most of them have been recalled due to the FDA back in 2018. So we're looking at what is the best way to offer skin to skin and to maintain that thermoregulation for both mom and baby. I love this photo just because, once again, you start to think of the OR as baby's first ice bucket challenge. Once again, the baby's temperature is that 98.6, and the OR being at 65 degrees is 33.6 degree temperature difference. So like for most of us, right, we've been in a swimming pool that is about or a hot tub that's about 98 to 100 degrees. And then we've all done the wild thing where we went and jumped into the swimming pool and it feels freezing cold. And the swimming pool set about 78, 79. And this is only a 20 degree temperature difference. Can you experience now and think, what would a 33.6 degree temperature difference feel like for these babies? It's got to feel like shock. Even in a labor room that's kept in between 67 and 70 degrees, that's still a 25 to 28 degree difference, which is still a major temperature shock to these babies. And now that we're closing a lot of the nurseries and moms are rooming in with their babies, the rooms are kept at a cooler temperature as well. So these babies aren't able to maintain the thermoregulation as they did when they were sent to either the nursery or when they're being taken care of in the NICU. And so what we've seen is even at nighttime when the temperatures are cooler, or if there's a male in the room, the temperatures tend to be cooler. And so once again, this is a 30 degree temperature difference. One of the things that we always say is zero separation is best. And I think most people have seen, all the literature and studies that have shown all the physiological and psychological benefits of Kangaroo Care and skin to skin for both preemies and low birth weight and regular on time baby births. And the WHO definitely advises immediate skin to skin care for survival of the small and the low birth weight and the preterm babies. Now, I love zero separation. I definitely wanted my babies right there beside me once I gave birth to both of them. And, when a mom and baby are skin to skin, the mother's chest, like I said, it actually adjusts to the baby's temperature, depending on if the baby is too hot or too cool. And it can actually lower or raise the temperature. Just recently this year in 2023, the WHO actually released new guidelines. And now they're saying that the baby should go, and this is for low birth weight and preemie babies, also that they should go straight skin to skin immediately after birth without the initial period of an incubator. And, even according to the World Health Organization, prematurity is an urgent public health issue. Every year, an estimated 15 million are born premature, accounting for more than 1 in 10 of all births globally. And even higher number, over 20 million babies have low birth weight. I know both two girls fell into that category. And the number just continues to rise. Now, prematurity is now the leading cause of death for children under the age of 5. So what can we do to help with these babies? How can we assist them to give them better thermoregulation, whether it's in a labor room, the operating room, postpartum room for mom and baby, or in the NICU? There's new studies that have shown that the continuous skin to skin is definitely a benefit for thermoregulation.
Mary, thank you
Any
so
questions?
much thank you so much for your presentation. Definitely we need to talk more about thermoregulation. I don't think something that we talk broadly and something that parents not necessarily know. I certainly didn't know about thermoregulation until recently, and I've been doing this work for 10 years now. So there's a lot that we need to learn as parents and parent organizations to be able to advocate and work together on that. So my question to you, as in your days as in labor and delivery, where is the disconnect between the teams to provide that moment for parents of the skin to skin immediately after birth?
Yeah, that's a great question. So one for, C-sections definitely came secondary. We've started doing the skin to skin immediately after birth for the vaginal births. And then it took a few years for us to start incorporating that into the OR to try to incorporate skin to skin at that point. I think thermoregulation, I think a lot of us kind of tend to forget how cold and what a difference it is for these babies that are coming from this warmer temperature and experiencing these lower cold temperatures. Also like for us, when we're in the OR, we have on our scrubs, then we have on all of our gowns, and then we're underneath the lights so for all of us, we're feeling hot, we're warm. And I think we kind of forget this is a naked, wet baby that can't maintain its own body temperature. And I think it's just kind of a little bit of a disconnect. And, we try to do the warming of the blankets and all of that. But in all reality, I think maintaining just that skin to skin and just education, I think, in products, those are the two things. And it's hard to kind of create that change in hospitals where we are incorporating a new practice or a new standard level of care. So I think that's pretty much.
So a lot of parents don't know the long-term impact of, when the baby is cold, because it does affect the baby's development. Can you talk a little bit about that? What is the long-term or maybe short-term impact of that?
Yeah, so unfortunately, you've got the morbidity and the mortality, but, the vitals start to drop, baby's oxygen sats, just their thrive to live, unfortunately. So you start seeing this, where babies aren't wanting to eat, babies are disconnecting. And I think it's just the long-term health issues that really come. And unfortunately, the mortality, I think, is the biggest concern that we are faced with today, especially for low birth weight and premature babies.
Yes. So Mary, thank you so much for joining us here today. It was a pleasure talking with you, learning from you, and I do hope I see you again soon in our Preemie Chats.
Thank you so much, and happy Mother's Day to everybody that's watching.
Absolutely. Thank you so much. And to all of you watching us live today, thank you so much for joining us today on this special episode of our Preemie Chats, talk about Kangaroo Care. As Monday, it is World Kangaroo Care Awareness Day. A special thank to our sponsor, AstraZeneca, who makes education sessions like this one possible. And just a reminder, if you missed part of today's session, head over to CanadianPremies.org. Let me share here our website if I find in my list. It is CanadianPremies.org. I can't see right now. Here you go. There you go, CanadianPremies.org. And we have all past episodes of our Preemie Chats. And you also find many resources and support options available there. And you also be reminded that CPBF is a charitable organization and depends on support to continue its important work. Consider how you can support CPBF and its mission to empower families of premature babies in every step of their journey. Together, we can create a brighter future for all premature babies and their families. And we'll see you again next Friday, 1 p.m. Eastern Time. Stay well.